Thank you very much. And I'm really honored by this very kind invitation to present the Pakistan Association of Urological Surgeons lecture on setting up a cost-effective endourology service in a resource restraint environment. I am Hammad Ather, Professor of Urology at Khan University in Karachi. Pakistan is the fifth largest country in the world with a population of over 220 million. And Karachi, where I work and live, is the largest city, the port city, with a population of about 22 million. Pakistan Association of Urological Surgeons was founded about over a quarter of a century back. It's a very vibrant organization. It has over close to about 1,000 members, full members now. This is where I work at Khan University in Karachi, and we have a state-of-art the Innovation and Training Center with good quality virtual reality simulators for training endourology. These are some of the workshops that we regularly hold on laparoscopy, on the endourology with whole beam laser resection, TUR, TURBT, etc. So urology in a spirit is essentially minimally invasive surgery. Endourology, laparoscopy, robotics are all part and parcel of urology. It's a very technologically dependent specialty. By virtue of this, cost of healthcare escalates exponentially for urological patient. And this cost burden is taken up by purchasers, which is private and public sector, both the providers, which are hospital and physicians, and ultimately the patient. Unfortunately, significant proportion of private patients in Pakistan pay from their pocket. The health insurance is in the earlier stages, and not more than 20% patients end up having an insurance. So we have to be economically cognizant. And we need to look at the cost effectiveness of any new technology. We have to look at the cost benefit ratio, and the cost utility analysis has to be done in order to use it in a country like Pakistan and other low middle income countries. So in order to define cost effectiveness, we have to first define effectiveness of a treatment. For urolithiasis, stone-free rate is the default setting to define effectiveness of a treatment. Many years back, we wrote this paper in Journal of Endourology talking about the efficiency quotient rather than the actual stone-free rate, in which you incorporate the additional treatment, the times of treatment is administered. For example, for ESWL, if the treatment is done more than once, the effectiveness of a treatment decreases. So it's important that we have the correct definition for effectiveness. Once you have done that, the important thing is to determine the cost effectiveness of a new treatment. Now, if the new technology the cost of new technology is less and effectiveness of the new technology is more, there is no doubt that this should be incorporated into the armamentarium, even for low and middle income countries where there are issues with resources. Endourology is highly dependent upon imaging. And it was some 20 years back, this paper, Danish paper, said that intravenous urography, which has served the urological community for many, many years, nearly a century now, need to retire, and new treatment, new imaging modalities should be incorporated. That's a time and point where the CT became the more or less default imaging for most urolithiasis patients. We wrote this paper about over 10 years back, in which we talked about the paradigm shift in the imaging of ureteric colic. And is it time to say goodbye to an old trusted friend, which was IVU? So if you look at our own data, and this is over a period of 2002 to 7, even at that time, as you can see, in adult patients, the number of IVUs done falls significantly, and the number of CT scans, mostly non-contrast CT, increases significantly. The trend was not that remarkable in pediatric patients, but it follows the same trend. As you can see, there are more CTs performed rather than the intravenous urographies. Let's talk about the treatment of stones in various locations, and I think that's the theme of the major bulk of our work. Urethral stone, perhaps the most commonly treated pathology in majority of the urological centers around the country, being in the stone belt. This is a paper that we have written a long time back in British Journal, and even at that time, looking at the data from 1987 to 1998, we noted that the urethral lithotomy, the numbers of urethral lithotomy gradually started to go down. The lithotripter was introduced in our hospital in 1989, and at that time, we started to see a little surge towards more lithotripsy, and ultimately we did realize that not all urethral stones can be effectively treated by lithotripsy. At that time, we had a 13.5 French ureteroscope only, and subsequently in 92 onwards, we acquired 8 French ureteroscope, and you can see a little surge in the ureteroscopies which were done, and subsequently when we had a final ureteroscope, 6 French semi-rigid, the number of ureteroscopy started to increase and the number of lithotripsy started to fall down. If we look at later data, and this is unpublished work, you can see that urethral lithotomy is really at the bottom, with hardly 2 to 5 procedures done per year, whereas lithotripsy was a significant number in the early 2000s, and subsequently, as the scopes become finer, more of ureteroscopy is done for ureteric stones, and I think that's a trend all over the world. What about kidney stones? And kidney stones, again, open surgery is becoming, even in our part of the world, a dead art. If you look at this data from 2006 to 2022, open surgeries for stones in adult population was significantly low. And a very similar trend is also noted for pediatric patients as well, because a vast majority of pediatric patients are dealt by lithotripsy. And once we had the finer endoscopes, significant number are now treated with percutaneous surgery as well. So we do about over 100 to 150 PCNLs per year, and the numbers are increasing with the finer scopes that are being introduced. In 2015, we acquired our first flexible ureteroscope, and that was the Cobra from Wolf, and it has been serving us quite faithfully over the last 7 years. The Boston Scientific LithoView was also introduced, but it didn't gain much ground because of its cost. The single-use Chinese and flexible ureteroscope like Pusen, and then subsequently OTU and some of the other varieties were really made a huge difference and an impact on the use of flexible ureteroscopy all around Pakistan, and because of the cost factor. If you look at our own hospital data, introduced in 2015, and gradually the confidence increased. And we were doing close to about 60 to 70 procedure per year with flexible ureteroscopy, and majority of the time we used the flexible disposable scopes. Now there is data about reusable versus disposable. Chapman's paper some years back indicated that the disposables are more cost effective, and this is in a US setting, in the Western world setting. And if you look at our own data, we had 5 Wolf Cobra ureteroscope. These are obviously fiber optic reusable scopes, and we have been the first one was used for fewer procedure, then we had damage, and subsequently the last one that we still have that has been so far used for over 75 procedures and still functioning. The overall cost of this is close to about 100,000 euros, whereas the cost of disposable scope is about 30 to 40,000 euros. And so that's our experience as well, the disposable. But mind you that we use disposable scopes 3 times. It has to go through the infectious disease evaluation, and they recommend that it can be used once properly sterilized for 3 times. So that's how we were able to cut the cost down. Now, we can't afford to have 2 procedures for flexible ureteroscopy. So majority of the time, if the ureter is naive and is not had any previous stones in the past, we do use 6 French semi-rigid ureteroscopy. We use metal dilators as well in order to do the procedure in the first go. And that's very important because otherwise it doesn't stay. Very rarely we have to put a double J stent only, and then obviously the patient has to have 2 procedures. This is the typical trolley, and you can see a semi-rigid ureteroscope, the ureteric metal dilators, which are reusable, 8 French rigid ureteroscope, and then we have the Cobra scope that we use. Percutaneous nephrolithotomy, again, is the mainstay because vast majority of our patients have significantly large stone burden. The training and teaching of these has been important. Now, because of the introduction of mini and super mini and ultra mini PCNLs, although we didn't have an access to all those kinds of scopes, and since the market is relatively small compared to India, I have used the McDonald's straw, properly sterilized, obviously, and the semi-rigid ureteroscopes to do mini PCNLs, and we've been very effective using laser. Laparoscopy, again, had a relatively slow start. It was started by one of our pediatric surgeon in the urological care, and subsequently we started to do it in adults as well. The number of procedures that are being done has increased steadily over the years, and we hold regular courses in which we have faculty from within and outside Pakistan who come and teach our trainees, and we certify 10 urologists every year with advanced laparoscopy in our simulator labs and on live models as well. So, old saying, Hippocrates said it 2,500 years back, that I will not cut persons laboring under the stone, but leave this to be done by practitioners of this work. And practitioner of this work in the modern era is really who knows how to do it in a minimally invasive fashion. Success, really the difference between success and otherwise is not lack of strength, but essentially is the lack of will. So where there is a will, there is a way. Thank you very much for your attention, and I hope you'll enjoy the rest of the meeting.